Corey Thornton. I'm the Managing Editor for Market Intelligence at Open Minds. Today, as part of our weekly Executive Web Forum series, Dr. Peggy Terhune, President and Chief Executive Officer of Monarch, will discuss thinking on your feet now while planning for the future. Dr. Terhune has been the CEO of Monarch since 1995, and under her leadership, they have implemented evidence-based and best practices and effectively developed programs to serve consumers with multiple disabilities. Before I get started, I have some housekeeping reminders. Your audio will be muted today, but we rely on your questions and comments via the question box on the right side of your screen. You can send those questions throughout, and Dr. Terhune will answer them at the end. The slides and recording for today's briefing will be available on the Open Minds website by tomorrow. And with that, Dr. Peggy Terhune.
Thanks, Corey. So today we're going to talk about what we've been doing at Monarch. And Monarch is a nonprofit, and we've been around since 1958. Today our budget is $93 million, but when I came to the organization 25 years ago, our budget was $4 million. So we've grown it a lot, and it occurred to me the other day when I was talking with someone, another provider in the field, that I should share with you that Monarch is an early adopter. We tend to jump on the new trend early and figure out how to do it, typically for several reasons. A big reason is if we can figure out first, we can often influence the state policymakers in how to set up the rules or how to modify the rules before everyone is doing it one way and it's just too big a ship to turn. Also, because if we can jump on it early, we can frequently influence software developers in how they modify their product. One of the first electronic health records that we worked with actually worked with us to create changes for their other clients so that we were the ones setting the standard for the rest of their folks. So we're an early adopter, and we tend to do things before other people. And that has served us well, and that's part of why we've grown. We have around 1,700 staff. We serve 3 different populations, all ages, and we do such a wide array of services. It's hard to find something we don't do, although there are some things that we deliberately haven't done. And when I say that, part of what happened in North Carolina was in about the year 2000, our change began, and we started into mental health reform. And at that point, we were small. We had probably, maybe 15 different group homes. We served folks primarily with IDD, but we had a few small homes for people with mental health issues. We had a developmental day program. We had what back then, state-of-the-art sheltered workshop program. And we had a choice. We had to decide, were we going to stay kind of a niche program, or were we going to expand and grow and expand the number and types of services that we were doing? And some of our sister agencies decided to stay a niche agency. For example, I'm only going to serve people with autism, or I'm only going to serve a certain group or age or type of person. And I looked at everything I had learned in business school and decided that we needed to do something completely different. We needed to expand to lots of different services and lots of different populations. And the primary reason I did that was because I was looking at revenue, and I knew I was listening, and I always listen with interest to Open Minds, and I was listening to the conversations about diversifying revenue. And I knew that sometimes a service would make money, but that 2 or 3 years later, that service might fall out of favor, and that service might start getting its rates cut, and that service might lose money. So I decided that the right approach was to expand our services, to add new and different types of services, and that would be the best option. And I'm going to revisit that concept at the end of this program to talk about what I think should be in the future for provider organizations. So Before COVID hit, I was watching all of these for-profit, regular companies, not in our industry, sending their workforces home. And many, many big companies were doing this. And they seemed to have benefit from it, and they were talking about it a lot in the business literature. One of the things I never do is stick my head only into our industry. You learn a whole lot if you find people from other industries to learn from. And in fact, one of the ways I've grown our agency is by hiring people that know nothing about our agency. One of my great finds was a gentleman who had worked in the tire industry, and he was a black belt Six Sigma and knew everything about process. I brought him in, let him do some visits, blind visits, with a script to our various outpatient sites. And it was very interesting how he was diagnosed differently in different sites, and how he was diagnosed as urgent in some and emergent in some and routine in some. And I was like, oh, we got a problem. And he began helping us work through our processes. And that was awesome. Someone in our industry wouldn't have seen what he could see. So I think you need to look outside of our industry often for ideas. So I was looking outside our industry, and I saw all these companies doing remote workforce. And then I saw them all bringing them in. And I remember when Yahoo in particular brought their entire workforce back in. And I read the research about why. Why did you bring all these people in? And there were specific reasons that they brought people in. And the reasons were primarily that they had lost a lot of the teamwork. People felt isolated, all sorts of things. But I had sort of thought, that's when I bring back in all of the social service mindset that we have in our industry. We know how to create teams, whether they're virtual or whether they're face-to-face. We know how to help people from feeling isolated, even if they're sitting alone in an office. So I realized that I could save $1.8 million if I made all of our administrative services remote. Now you have to remember, I had already given us an electronic health record. I had already created a human resource information system, an HRIS system, and we currently use Workday, which has been an excellent system for us. You don't usually hear people talk positively about their software systems, but we like this one. We had our electronic health record, we had our financial package, and I thought this would be a great idea. We were doing about 30% remote workforce. So, and this is the building that we were living in, and my staff had taken over the bottom floor, and then they'd taken over the next floor, and then they decided they wanted to take over the next floor. So I decided to do something different. I knew that there would be legal issues if I sent people home, and I was going to have to figure out how to make sure we were still paying attention to HIPAA and all of those things. I'd need to keep strong teams, which is why the business world was bringing people back. I'd need to monitor output to ensure that productivity was still happening. I'd need to figure out how we were going to communicate, because the water cooler conversations were frequently a way that communication could happen. And I needed to determine who was able to do this and who wasn't. We hadn't hired people thinking you're going to work at home by yourself. We'd hired people thinking you're going to work in an office and your supervisor's going to be next door. So what was I going to have to do to fix that? Well, we did all that and figured it out, and I've talked about that before. And it all was working beautifully. We were communicating better than before. My staff loved it. We had learned lots of lessons. And then March 19th, we got the word that the governor was going to close the state the next day. What do we do? Well, we have a system at Monarch called Incident Command, and I have found this to be an extremely useful tool. We manage it through our quality management staff. One of them is the director of Incident Command, and anytime she perceives that there is a need to get together, we call Incident Command. It's typically a virtual meeting. We typically meet at 4 o'clock in the afternoon. She calls in anyone she perceives is needed. Typically, it's all administrative departments and all key operational departments. And we've done this for hurricanes. We've done this for, well, hurricanes come to mind. We've done it for major snowstorms. Yes, we have snow in North Carolina. We've done it when there's been any sort of traumatic something that we all needed to deal with. So COVID was obviously the next step. Oh, the governor's going to close the state. What are we going to do tomorrow? And so this is an awesome way to bring 30, 40 people together. Everybody hears the same thing. Everybody gets their marching orders, and everybody can go out and then inform their teams and so on and so forth. And so what we do with Incident Command is we start by saying, okay, what do we know? What do we need to do today to get ready for this? What are we going to do tomorrow? And what do we need to do next week? It's a very initially short-sighted perspective. We're not looking at what are we going to do 3 months from now. We deliberately keep that first Incident Command meeting always very today and tomorrow and maybe next week focused. So that's what we did. And so we came up with some answers. We need PPE. We didn't have a lot of it. Nobody had a lot of it. Where are we going to get it? So someone was assigned directly to go do that. We have an infection control department, but they weren't going to be able to handle the overwhelming need to get PPE because we were going to have to search out a lot of sources. So who was going to go check on masks? Who was going to go check on gowns? Who was going to inventory what we had? We have 150 sites. Who was going to find out from 150 sites what we had, right? And that's not to discuss even the community teams. What did the ACT teams actually have? What did the maintenance people have? Where were we going to be able to get more PPE if we couldn't purchase it? Gee, I wonder if the plumbers in town would share with us. Could we get it from, did anybody have a contact? Big agency, lots of people, let's use our sources, right? So that's part of the way we use this Incident Command. Well, our immediate thought was, well, we can take all outpatient virtual. How are we going to do that? Well, let's see, 30% of us is already virtual, but we're going to have to get all the right equipment in everybody's house. Well, how many providers and therapists do we have that don't have it? Where do they live? Okay, how many IT people do we have that can go set up software? How much software do we have? What do we have that we could deploy elsewhere? What do we have to order? How fast can we get it? So everyone was assigned those types of things. We need to immediately close all our day sites. Who's going to tell the families? Who's going to tell transportation? All of the questions to go with this. You can see the kinds of issues. What about crisis residential? We have a 16-bed, for example, facility-based crisis program for children and adolescents. Can we keep it 16 beds? Not there. We have mostly 2-bed bedrooms. We have some single bedrooms, but mostly 2 beds. But there's another crisis program that we run that had single bedrooms. Could we keep the single bedrooms? Well, somebody needs to go find out if you're sleeping and you're 6 feet apart, does that the same as social distancing 6 feet apart? And the answer was no, it's not. That actually COVID spreads worse at night when you're sleeping. We didn't know that then. We had to find that out. So we had to ask all these questions. Who's going to find that out? Then we thought about all the people that needed to be in the field. So of those 17 staff, we realized that over 1,000 of those staff are going to have to stay in the field. We have ACT teams. They go under bridges to find homeless people and give them shots. That can't be done virtually. We're going to have to get our staff still doing this. Well, what if our staff can't do this? What if they say they're significantly at risk and they could die if they're exposed? Or what if they have an elderly parent that they take care of and they're not willing to risk? And what if they have children at home or a new baby at home and they're not willing to risk? How are we going to deal with this today? What answers are we going to give them today when we tell them what's happening tomorrow. So we came up with some really fast plans on this 4 o'clock meeting, just, to figure things out, knowing that we were going to meet the next day at 4 o'clock, bringing back as much information as we can. And by the way, when we do these, everyone is looking at a screen that has a spreadsheet on it. And on the spreadsheet, we're assigning people, we're assigning what's going to happen, we're typing it in real time so everybody can see it. And then it's posted on an internal system where everybody can access it at any time. And then we said, okay, our staff, we can't lay them off right now if we don't need them. Let's talk about furlough. Let's go investigate what we can do so that our staff aren't harmed, because we obviously need our staff. We've got to do something. Let's see what we can find out. So that was the next step. Met on Friday, found out information, thought we were doing good. And then the next thing that happens is Monday. So Monday, I'm feeling pretty good about things, and I'm taking immediate steps, and I'm leading this group, and I'm thinking, okay, we've got this. We're going to figure this out. We've got everything in process. And all of a sudden, the chief medical officer calls me and says, the sky is falling. People are coming into our outpatient clinics, and we're only going to let them come in if they say they don't have a temperature, right? And so they're going to come in, we're screening them at the door and saying, you can only come in if you have no temperature. And then when they come in, we're going to take their temperature. And guess what? People are saying, no, I'm not sick. And then they come in and we take their temperature and they have a temperature. And she calls me at about 10:30 or 11 o'clock in the morning and says, we can't see anybody this afternoon. We have to close these clinics right now. We have to do it right now. We can't wait till tomorrow. We have to do it right now. These are the kinds of things that happen all the time in this kind of scenario. And short-term thinking has to be there. And as the decision maker, you have to be able to figure out what are you going to do with crisis people when they call you and they're losing it and you don't know what to do. So we made some really fast decisions and decided what we were going to do, how we were going to go online more quickly than even tomorrow, and move some things around and figured that out. So again, I'm thinking, okay, we've sorted that out. So what happens on Wednesday? Wednesday, what amazes me is many staff are refusing to work. I knew some people would refuse to work, but I didn't realize we would have so many people refusing to work. Remember back to March, we didn't know how serious this really was. But all of a sudden, all of these staff are saying, I can't work, you have to pay me, but I'm going to stay home. I can't work, I have a medical condition. Well, let's see, are we going to require that they prove they have a medical condition and tell them they have to go to the doctor? Well, I don't think that's going to work because the doctors are refusing to see people face to face. And the doctors are saying they're only going to take crises appointments at their offices. And the doctors aren't online yet. What are we going to do? Now they say they have kids at home and no sitter because the schools have all of a sudden closed. What are we going to do with this? Well, they have elderly family. Some staff are saying, I don't want to work. I'm afraid. I'm afraid I'm going to get it and I'm going to die. I don't want to work. So we start talking about hazard pay, and we start talking about how much hazard pay are we going to pay? And in the back of my head, I'm thinking back to those ethical questions that we used to ask in graduate school. What's the value of a human life? If somebody dies and you have to put a value on their life from the insurance company, what's the value of a human life? So we pay them $5 an hour more. Is that really enough to encourage them to do work that might kill them? Is that really fair? But we're Medicaid funded and state funded, and we don't have boatloads of money. And so what am I ethically asking people to do when I consider giving them hazard pay? And I can't afford to give them all hazard pay, 1,000 people to go work every day. What am I going to do with hazard pay? Am I going to pay it? We finally decide that we'll only pay hazard pay if people actually are working with someone who's COVID positive. And that was kind of where we landed. Well, what happens next? Next week on Friday, beloved Donald Trump says, this is terrible. It's terrible to get tested. You don't want to test. They stick this thing in your nose and it goes so far back and you choke, and these tests are terrible, and he demonstrates, how horrible it is on TV. And like it or not, North Carolina probably will end up have voted for Trump. We have a strong Republican base here, and many of my direct support staff in particular voted for Trump. And of course, we can't be political. And so they believe him when he tells them that getting a COVID test is a horrible thing. So all of a sudden, the next week on Friday, one person who lived in an intermediate care facility goes to the hospital, is likely to die, and 3 other people in that group home are infected. It's Friday afternoon. We find this information out, the positives, on Friday afternoon. Everything always happens on Friday afternoon at 4 o'clock. Yep, that's when it happened. So the staff find out that the residents are positive, and they say, we refuse to get tested. We aren't going to go through that. Donald Trump said it's a horrible test. We're going to just stay home for 14 days instead and quarantine, and then we'll come back to work. We're not going to take the test. Every single direct care staff said that. So of course my staff look at me and go, what do we do now? We don't have staff to pull from other group homes. We have so many people that have called out or said they can't work. We're already down to about half our staffing levels. What are we going to do? Where are we going to pull people from? Because now not only are we asking people to work extra shifts, but we're asking them to work with people who are actively COVID. We do have enough PPE, but not gowns. We go out and we buy painters' overalls, and we ask staff to wear these painters' overalls over their clothes, put them on when they walk in the door, take them off when they walk out of the door, the whole thing. We've got shields, yay. We've got gloves and masks. And believe it or not, our management staff stepped up and covered that group home over the weekend. And staff gradually began to come back because we said, if you want to take 14 days off, that's fine. But unless you're using your paid time off, we're not paying you for this time. There's no extra time to get paid for. And staff began to realize they weren't going to be paid. And that was the only ace in the hole that we had. Well, the next thing that happened was the PPP loan came out, and we're a big agency. So we looked at it initially and said, well, we don't qualify. Darn, everybody else is going to get this money and we're not. And then we discovered that it had a category for alternative size. Well, we were alternative size. We fit that definition. Under the 500 and less definition, it said nonprofits may apply. Now, what's significant and important about this, and this is why it's important to have typically a friendly attorney that you work with on a regular basis, even if you don't need an attorney often, I strongly recommend that you have an attorney that knows your business and that you trust. So we went to our attorney who said, well, Peggy, there is an alternative size definition, but the Small Business Administration has never allowed people that are nonprofits to apply for their funds. This particular law says that nonprofits can apply for this money if they're 500 or less number of employees. Okay, well, we're alternative size. What does it say about that? Well, Peggy, it doesn't say. So if it doesn't say, can I apply? Well, I don't know. It doesn't say you can, and it doesn't say you can't. Well, it's the same law, so I'm going to assume I can. What do you think? Well, Peggy, it's worth a try. So we apply, we send all our info. We're very clear. We are larger than 500 employees. We are a nonprofit. We don't know if we are eligible for this, but we're sending in our request. Next thing we know, we get approved for a $10 million loan. $10 million. Like, that's like, for us, that's like a gift from heaven, right? And we're like, we got $10 million. Does that mean we qualify? Well, we don't know. My CFO says, I'm not going to certify that we qualify because they haven't really told us we qualify. They just told us we could have $10 million. We had called them. We'd gotten 2 different answers. Yes, you completely qualify, and no, you don't qualify. We'd sent a letter per the attorney to the people that should have been able to tell us. I want to say it was the Attorney General's office or something, and no one has replied. So many people are borrowing so much money, and the legislature is moving so fast at the federal level, and nobody's looking at this stuff. We don't know if we're eligible, but I know, because I'm thinking big picture, that first of all, nobody's going to answer this question for 2 or 3 years. And if we don't take it now, we'll never get it. And if we send back that 10 million, the chance is lost. So we took the 10 million. I certified that we were eligible. And then we spent that 10 million, but we took 10 million of our money and set it aside. When they come back 2 years or 3 years or whenever they come back, we will have that $10 million set aside. If they tell us we didn't qualify, we'll hand them their 10 million back and say, thank you, it was a fun dream. If they tell us that we do qualify, then at that point, the agency will have an extra $10 million to start a capital campaign or something with, or to build whatever. We're playing it carefully, conservatively, but we're keeping that $10 million. And that's at the direction of the board, our attorney, and the bank that approved us. Why did the bank approve us? Because they know us too. Again, good banking relationships. So what do we do next? Well, 5 months in, we realized we were still paying insurance for those people we had furloughed. So what we did was we didn't lay them off. We furloughed them, meaning they weren't actually laid off. We had work for them. But after about 5 months, we realized some people simply weren't coming back. They were the folks that had major lung damage, and they just weren't ever going to be able to come back. And we had tried our hardest to find them positions that they wouldn't ever be exposed, but there were just too many direct support staff, and we just didn't have that much in the way of admin work for them to do. So we realized they weren't coming back. We asked them if they would pay us back. Many of them told us they couldn't. And so we added that money for their health insurance to what we keep this running list of COVID expenses. Both our state and the money that we borrowed from the feds and several grants that we got for COVID expenses want us to account for how we're spending that money for the COVID expenses. Well, that health insurance that we paid for, that no one is giving us the money back for, that's a COVID expense. So that's one of the ways we're justifying the money we spent. But the next thing that happens is my CFO says to me, Peggy, we have too much COVID money. How can we justify spending it? I'm going to send $1.6 million, this $1.6 million we were given back. I don't think we can justify it. They want to know that we lost too much money, and quite honestly, we've gotten so much more efficient with our using our telehealth and our telemedicine platforms, and we're actually making more money now than we were when we were face to face, and we're just not losing the money that we should have lost. Want to send it back? Let me send it back. No, you can't send it back. You need to run a report and figure out We were working on these efficiencies before COVID ever happened. We were 30% telehealth, but our goal was to get to about 75% telehealth. So you need to figure out, assuming that we were meeting our goal, where would we have been if we hadn't had the other COVID problems? Because we would have been in a better place today if people weren't dealing with COVID than we are. We would have been making more money than we are. You need to figure that out and put that down as a proposed loss. Will it work? I don't know, but it is a legitimate argument to make. So that's the argument that we're making on that. So let's talk about what's next. We're hearing all this information now about a vaccine. It's going to be ready. It's going to be ready. Yay. Well, in June, looking ahead, it was obvious that COVID would last at least a year. By September, it was clear this was going to be a 2 to 3 year battle. By October, Dr. Fauci was telling us that even after a vaccine was available, we would need to use masks. I want to explain to you that, in my opinion, that vaccine that is going to be available really soon is not going to be the answer, and that we probably are in this road a lot longer than we think. Think about that vaccine. Think about the fact that there are billions of people on this planet. And in order for us to be safe, billions of people need to get that vaccine. I think about when I was a child and polio was a big deal. And I remember as a little girl, we went nowhere, ever. And it wasn't until I was probably 5 or 6 that the polio vaccine came out. And then at that point, I can remember standing in line in a big gymnasium to get my sugar cube with my sweet polio vaccine on it and eating the sugar cube. But I can tell you, for 5 or 6 years, we went nowhere. We didn't go to parties. We didn't go to parks. We didn't go to state fairs. We didn't go anywhere that we possibly could have gotten polio. You think about the 1917 flu and what happened with that particular situation. Russia has a cure. If you read carefully about that cure, you either recover or it kills you. I'd rather not take their cure. I think they have a lot more work to do. We're going to be in this for at least another 2 to 3 years. If we get a vaccine, the population in the United States might take it to the tune of about 50% within the next 2 years. That's the best guess. That means 50% of the people will still not have the vaccine and will still be able to get it and give it. And the vaccine that they've created, they think will work, and it might. How long? We don't know, and we won't know until time has gone on and whether people will get it again. And think about the flu vaccine. Why do we take a flu vaccine every year? Because this particular flu disorder that we get changes. The original assumption was that the COVID vaccine couldn't change. That was what everyone said. We'll get a vaccine and it'll be like polio, and you'll take the vaccine once and it won't be able to mutate and we'll all be fine. But the newer discoveries are that people are getting COVID again, and it's a slightly different strain. Follow the science. This is not going away tomorrow. It's not going away next summer, and you're in this for the next 2 to 3 years. So what's really important is to think strategically, to plan strategically for how we're going to go through the next 2 to 3 years, and then to plan strategically for, let's pretend this is over tomorrow. Where are you going from there? So one of the things that I've been seeing my staff say to me is, when things go back to normal, we will. And I stop that talking the minute they say it. Because first of all, we're never going backwards. That's the wrong direction. We're going forwards. And so people can never go backwards. Worlds never go backwards. We know, for example, that many people are experiencing trauma as a result of COVID. We know that people that have COVID are experiencing mental illness at a significantly higher rate, as are their loved ones. I think the trauma of having it and the thought that you could get it seriously and die, or as Chicago Med talked about last night, there was I don't know if you had a chance to see it, but there was a wonderful section where one of the doctors had a daughter, and the daughter gave COVID to the dad, and she was devastated because she thought she had killed him because he was older than she was, of course. And so she thought that by acting stupid and giving COVID to her dad, she might have killed her dad. The emotions and the concern around COVID are not going away soon. So the mental illness and the collective trauma to our country and to the people in our country is also going to last a long time. We know a lot about trauma in our industry, and we know that even if you treat trauma, 5 years from now, 10 years from now, 20 years from now, it can still come back to bite you. And so we need to think about that, and we need to not think we're going back to yesterday. We're going forward to tomorrow. So what do we need to think about as we go forward to tomorrow? Well, first of all, we need to budget for change. I always budget for change. I always assume that change is coming around the corner, one way or another. No, I didn't budget for COVID, but I budgeted for change. I knew something would happen. I didn't know whether the state would go bankrupt, or there would be a brand new service that nobody would have enough money to fund, or I don't know, we'd have another huge hurricane that would devastate the state. I don't know what tomorrow is going to bring, but I do know that tomorrow is going to bring something that's going to throw everything we know and do up in the air. Nobody could have projected COVID, but we can project that something's going to change, and we never know what. We've got to plan for it. We also have to know that one size will never fit all. We know that we will always need more technology, more hardware, and more software. Look at all the companies that have sprung up with their newest technology that you can use on your own. Take mindfulness, for example. Everybody has a new app for mindfulness. But out of all those new apps, there are 2 or 3 or 4 that are pushing their way to the top. Everybody wants to use Mindspace or one of the other apps that are really seeming to be the ones that people like. That's what happens with technology. Everybody jumps into the field to do their own thing, but gradually 2 or 3 or 4 areas kind of spring up. Think about when the internet first started, how many search engines we had and how many we have now that people use. Most people gravitate immediately to Google, although there still are other search engines, right? And why do you go to Google? Because it's more likely to give you what you want if you're searching something simple. And most of us are most of the time. But remember that one size will never fit all. So you can't assume that what you're doing today is going to work tomorrow. You can't assume that that one type of software is going to work for everybody. You also need to think about, if we're looking at change and if we're in the midst of change, that when things are in upheaval, that's a great time to make more changes. Think about it. When everything is going along nice and happy and everything is comfortable and working well, and you say, let's make a change. One of my favorite statements is, if it isn't broken, break it and make it better. And people look at me like, why would you mess with a good thing? It's working great. And I'm like, because we want to make it better. And they think you're crazy. And I'm like, yes, I am. And it's going to work better. But when things are a mess, that's a great time. That's a great time to look at, why do we have this position? I think that during this time period, we might not need that position anymore. That worked really well when we were on site all the time. But now that we're all virtual, that position really doesn't make sense. We've gone through almost all of our positions, particularly in outpatient, and said, in a virtual world, what does this position do? What position do we really need? So for example, one thing we've looked at is communication. We need to do follow-up, right? So when someone calls our office and says, I need a med refill, and we used to have a specific process for that med refill, and then we went virtual. And so the paper process or the communication process that we used to have had to go all virtual. Well, it wasn't working well. We needed to make sure we were following through with that process, so we had to tweak it and fix it. Well, the other day, a couple people that needed a callback didn't get it and complained loudly that they didn't get a callback in a prompt manner. Why? So we started getting these complaints that people weren't getting called back in a timely manner. And we started looking at our system, and the problem was we were thinking that just because we had gone virtually, we could operate the same communication system virtually that we had been doing on ground, and we can't. So we actually have taken a position that we used to have on site and added it as a new position, completely changed the role of the person to do it virtually, and their job is to make sure at the end of the day, everything is communicated back, that the nurse didn't miss any med refills, that the doc has responded to everything that came through the patient portal, that the front desk staff have responded to every single phone call that came in. There's actually someone who's following behind every one of those. Is that the best option long-term? No, probably not. But right now, we're doing that with the plan to turn that into a case management position that will then be able to follow along and track all these things and make that work better for us. So we're kind of skating into this case management system that we think will work for us. And we've started to explore case management software, because if we can start that case management software at the call center that will work for call center software and case management software, we're going to be able to track this stuff in real time and not let anything drop. So I'm thinking ahead. That call center case management software is probably at least a year out, but I'm planning already to budget for that. And so even though my staff aren't there at all, I'm already going there. So I'm thinking we're going to need more technology, and it's time to make changes. And so I'm trying to think of those sorts of things. I'm also listening to my staff when they say, well, when we get back, we won't have to do that, we'll have that position because we won't do that online. Wait a minute. If you can do that effectively online, don't go back to normal. Leave it online. It's more efficient online. It's more effective online. I am loving the ability to get online, type my doc a question through a patient portal, send it off, and get a response back through a patient portal. I don't want to have to pick up the phone anymore and call an office and leave a message and wait for someone to call me back. So why should we go back to normal? I don't want to go back to normal. My staff do. They liked it. It was comfortable. I'm not going to let them do that, but I'm going to have to fight them on that. Because people want to go back to their level of comfort. Don't let that happen. Also remember that as you go through this, you've got to provide massive, massive communication. I think I have never heard staff say, my company communicates enough. It's always a complaint of every staff in every company I've ever worked in, everywhere that I've ever been. And so what are we doing? Well, we do multiple town halls. We do them by department. We do them for the whole company. We do them by division. We deal with different topics, but we always allow questions and answers. And the reason we allow Q&As is because people have questions. And if they get too specific, we also have an email that comes directly to my inbox, and people use it all the time. It's askpeggy@monarchnc.org. We just gave out bonuses to all our group home managers. I got an email today. They all got a letter telling them they were getting a bonus. Got an email today saying, my bonus was only $457. You said it was $750. Are we getting it in 2 paychecks? And I was able to direct her to go back and check her gross pay, right? And she came back and said, well, why was it taxed? Now you might say to yourself, why is the CEO dealing with this, not HR? But you know what? That direct care staff can now say that the CEO took her time to explain her payroll to her. And wow, doesn't she work for an amazing company? And it took me 2 minutes, and I bought more customer service for that staff with that 2 minutes than anything else. Lots of board updates. When we started this, we were doing weekly board updates on Friday afternoons to make sure they knew what we were doing. They were in the loop. They were allowed to give feedback. They were giving us direction. It's wonderful for them, and lots more social media. Really important to do that as well. Key strategy issues, focus on the customer need. Put yourself in the customer's shoes. Use social media. Go and check yourself on reputation.com. Check the front door. Find out what people are saying about you. And if you're like us, the people that like to review us the most are the patients who come in and we refuse to give benzodiazepines to because they're already addicted to drugs from their primary care doc, and we won't continue. And they rate us and tell us that we don't care about anybody and all we are is mean and rotten and all that stuff. Find a way to fix that. So we just rolled out a system where after your appointment, you get a text asking you to rate us. We're trying to get the people that are happy with us to rate us, not just the people that are angry enough to seek out how to rate us online. Expand your operations. Now is a great time. Add new lines of business, especially substance use disorder and children. These are the areas right now in our industry that are the highest need. Everyone's worried about children's mental health, and we still have, by the way, that opioid crisis, even though it isn't in the media nearly as much. It's actually more prevalent now than it was before COVID hit. Grab that gold ring. Keep your ears open, keep your feet on the ground, and don't go back to normal. So Corey, that's our session. Do you have questions?
Yes, thank you, Peggy. The first question I think is obviously, would you do it again? Which I think we probably know the answer to. And when you did it again, what would you have done differently?
I would definitely do it again. And I think if I would do anything different, I think I would have worked harder to help my leadership team understand more calmly the direction they needed to go, because some of the, what do we do? What do we do? I was so surprised when my chief medical officer, psychiatrist, was freaking out. I should have really found a way to say, hey, wait a minute, emotion regulation, calm down, better than I did. We were all so tense. Everyone was in such a crisis mode. And while I was able to solve the situation, I wish I had stepped back and done more with my senior people at that time. I think all of us kind of thought this would be gone in a couple weeks. Back then, we were just in this crisis mode. I probably would have looked long-term day one instead of looking long-term at like the beginning of the third week.
Do you think that executives at other organizations, after stepping up to a very tough first step, should just bake a longer-term strategy? I mean, in the next coming year, this could happen again where, more organizations find that they kind of came back facility-based a little bit, but then we're seeing reports that in some states where they're locking down certain kinds of businesses. Do you think this is going to come again? And do you think that this preparation is going to make any other changes that are necessary easier on your end?
So I think that they are going to lock down again. Yes, we've even locked down again a little bit in North Carolina. And I think that's why I say don't plan to go back to normal. And I think that strategically, I'm always thinking 3 to 5 years ahead, always. And I think we always need to be thinking that way. Not thinking, where are we today? Where will we be in 3 years? But thinking, okay, change is going to happen. What direction is our industry going? What direction is our social world going? What's important to our whole world today? What do we see on the horizon? What are the social issues that our industry is going to have to deal with? Thinking about it strategically from that perspective, because we don't know what specifically is going to get funded, what specifically is going to happen. You know, I've joked with my board more than once that we can't really create a 5-year strategic plan because who knows what will be funded by then. But we certainly can look at the issues and have a really good idea of what's going to be on the radar. 5 years from now, that's pretty clear. I mean, we have all these states, for example, opening up, passing marijuana laws, and more of those were passed in the last election. Where's that going to take us? And what can we predict about that scenario? And what about if the whole country were to approve marijuana? Where is that going to take us? And let's look at the fact that the baby boomers are aging. And we're going to have, and we keep seeing, if you read a lot, and I encourage people to read a lot, the baby boomers are aging, and we know there's not going to be enough caregivers for all those baby boomers. So where are we going with that? With technology? Technology is going to be huge. Look at those social issues and position your organization to be ready to deal with them as soon as the rest of the legislators and industry is ready for that. Get yourself prepared.
Yeah, that's great advice. You know, one trend we saw this past year, and it's I would call it a long-term trend, the tech-enabled caregiver. But it was one that COVID went from long-term to short-term. A lot of telehealth got launched, and you know, we've been saying for years there's going to be more tech-enabled options. But now we're seeing reports that a lot of what got implemented, some organizations may back off that use, or consumers may want to back off that use. You know, in the long-term services space, what do you think the future of tech-enabled might look like? Are we going to see more adoption, or you know, are people going to say, you know, we like it a little bit and maybe not that much?
So with the long-term space, I think that, you know, Monarch has positioned itself there the way we had positioned ourselves in telehealth. It was really easy to see that telehealth and technology was coming, which is why we were already virtual with all our administration and had started playing in the tech space, the telemed space, even though there wasn't a lot of funding for it. Well, right now there's not a whole lot of funding for that technology in the long-term services space, but we already have 8 smart homes. We're already putting those technology adaptations in people's homes when we do supported living, when we do work environments, all those sorts of things, bit by bit, little by little, grant funded or other funded, because all of a sudden at some point there's going to be an explosion and boatloads of money is going to be poured into that. And companies that don't know anything about that and haven't dipped their toe into that are going to be scrambling to come up to speed. And so that's the kind of thing where I'm saying right now is a great time to dip your toe into that. Find out everything you can about that. Visit companies that are doing a lot of it. Go visit universities that offer courses into it. Get some of your staff, as we have, trained in how to do that, how to assess people for that, and what technology is out there. Learn about the companies that offer this, what they can do and what it costs. Just a quick example. There's an awesome company in Wisconsin called Night Owl. What they do is they put a system in somebody's home and they have a person sitting there at night awake in Wisconsin, and they zone your home. So suppose you have a bedroom and bathroom attached, but you really don't need to leave your bedroom and bathroom at night, because if you do, that would be a problem. If you walk out of your bedroom, someone live sitting in this console will talk to you and say, "Hey, Corey, I see that you're up and out of your bedroom. Where are you going?" And they'll talk to you. And if you don't talk back, they'll either call someone you know or the police or whoever it is you need. We've used this a lot with people that need to stay in their apartments. And if the front door opens, they'll say, hey, Corey, you opened a front door. Do you have visitors? Who's coming? And to know, are you safe or do they need to call the police? Huge, huge options there. A live person. We're using this actually to stop using overnight awake staff because that will decrease the funding and it will decrease physically using staff. And we've got several pilots going with this. That's the kind of technology you need to begin exploring. Now, can we do this all over the place? And is it for everyone? No, one size will never fit all. But is this an option perhaps for a family that wants to keep a family member home that wanders, that has dementia, and they don't want the person to get out of the house, but they want to get woken up if the person leaves the house? Yeah, that might be an option for that. Who knows about it? Very few people. So what can we do to help certain families get where they need to get, or people get served in places we need to serve? We need to be ready for when that explodes, we're ready to serve that population.
All right, thank you much. That's great advice. So we're coming close to the end here, and I know that talk of COVID often sucks all the oxygen out of the room, but there's a lot of other things going on. So my final question is, what is your final advice for our viewers? Keeping in mind, it doesn't have to just be about reopening, that after we get COVID under control, there's a whole other slew of strategic challenges out there. What would your advice be?
My advice is to wake up every day and be creative and think positively, because we live in this great, awesome world. And the minute you get yourself down, it's time to go find another job. So you know what? Read your open minds every day, because that's where I get all my ideas, and that's why we're so successful. How's that for a plug?
That is great. Thank you very much, Peggy. And I want to thank everybody for joining us today. And I want to remind everybody that our slides and the recording will be available online tomorrow, and that we will also be here next week on Thursday for the Executive Web Forum, Options for Managing Staffing Costs, Productivity Management, Outsourcing, Technology Solutions, and more. That features Open Mind Senior Associate Ken Carr and starts at 1 p.m. Eastern. You can sign up at www.openminds.com. It's listed under webinars in the events tab. Thanks again, Peggy. Have a great day.
You too.